We'll keep in our place for 3 minutes because of the translation. There is a problem within the translation. 3 minutes and we'll continue.
Shall we start? This is the last talk in the course, and I'm sorry that I'm going to discuss with you some of the nightmares that may appear in the hemodialysis session. What are the hemodialysis catastrophes? These are the agenda of the talk. What are the causes? How they are presented, how to manage it, and actually how to prevent it. This is the right statement. And I'm going to give some case reports about these catastrophes. These are some of the common catastrophes that could occur during the hemodialysis session. It includes catastrophic hemorrhage, air embolism, hemolysis, fetal anaphylaxis, and cardiac arrest and so on. First of all, we have to differentiate between the usual complications that could occur during the dialysis session, including hypertension, cramps, headache, etc., and the fatal catastrophes that we have just mentioned. Let's start with the first catastrophe, the catastrophic hemorrhage. The most common cause of catastrophic hemorrhage is needle dislodgement. Actually, this is very dangerous complications. That's why a group was created called the Venous Needle Dislodgement Special Project Workgroup. This work group reviewed the incidence of venous dislodgement and their consequences, and they recommended some guidelines to prevent this catastrophic complication. First of all, this is very simple and basic how to fix the dialysis needle. The needle should be fixed in place by a rectangular adhesive fabric. But most importantly, another adhesive fabric should be used under the dialysis needle, underneath the dialysis needle, and then it's flipped up in this way to ensure the fixation of the needle. There are some guidelines that were stated by this work group to avoid the needle dislodgement. First of all, the awareness, either by education of the patient and staff and using educational materials, etc. Number two, the area around the vascular axis should be large enough for tapping and should be cleaned and allowed to dry before cannulation. Number three, each hemodialysis unit should follow these instructions and policies strictly. The blood lines should be looped loosely to allow movement of the patient and to prevent blood lines from pulling on the needles. This is very important. And also it is necessary to, if it's necessary to reposition the needle, it's very important that we should use a fresh tap. Never use the old one. And the vascular axis and needle should be visible all the time during the dialysis session. And checking the vascular axis should be part of the monitoring process during the dialysis treatment, besides the vital signs, pulse, blood pressure, etc. So this is a very important picture. Please don't hide the vascular axis or the lines under the blanket. This is very important. This is some examples for some of the heroic and catastrophic bleeding that could occur, for example, from the ulceration and infection of the fistula that necessitated emergency and urgent tourniquet application. This is another example of fatal complication of percutaneous femoral castor catheterization with blood collection. This was fatal. The second catastrophe is air embolism. Although it's rare, however, it's fatal and it's usually presented with chest tightness during dialysis. It could be suspected when we found there is a foam in the venous blood line indicating that air entering the dialysis system. Could also occur due to disconnection of the connecting caps or blood lines if we dialyze the patient through central venous catheters. Actually, the symptoms of air embolism depends on position of the patient at the time of the event. If the patient is in the seated position, so the air tends to migrate into the cerebral vessels, leading to convulsions and loss of consciousness. However, if it occurs in the recumbent position, so the air will tend to enter the heart and lungs, causing dyspnea, cough, and chest tightness. How to treat suspected air embolism? First of all, we should clamp the venous line and stop the pump. Positioning the patient in the left side, supine position, with the chest and head tilted downwards. Start the cardiopulmonary resuscitation with administration of 100% oxygen, either by mask or endotracheal tube. Sometimes we use hyperbaric oxygen. And the most important aspect of air embolism, as I said, and in all the hemodialysis catastrophe, is prevention by adequate function and monitoring of the dialysis machine. This is some examples of what's reported in the literature: pulmonary venous embolism, air embolism following accidental patient laceration of the non-contrast per CT in the cerebral visits. And this is a common scenario for the development of air embolism. That's usually 10 minutes after the patient beginning to receive his dialysis session. The venous bloodline separated from the catheter, and shortly after the venous blood line was clamped, the patient complained of shortness of breath and increase in respiratory rate. Usually, he immediately placed in his left side renal position, giving up to 1 liter per minute of oxygen. And despite all these measurements, the patient usually dies. The third catastrophe is the catastrophic hemolysis. Acute hemolysis could occur during hemodialysis, and it's usually potentially fatal. The hemolysis could occur if the RBCs were exposed to different stresses, including oxidation, reduction, thermal or mechanical injury. These are the causes of hemolysis. We may use overheating of the dialysate, using hypotonic dialysate. If there is kink in the tubing, or physical destruction of the RBCs, malfunctioning of the blood pump, contamination of blood from lynch or formaldehyde or the different sterilizing materials, chloramine, nitrate or copper from the water supply. And this is some reports about the chlorine-related hemolytic anemia. It's usually used in hemodialysis, home hemodialysis patients. And this is another case of hemolytic reactions mechanically induced by kink in the hemodialysis lines. And these hemolysis could cause acute pancreatitis secondary to these kink in hemodialysis bloodlines. How to suspect hemolysis? The patient usually suffers from chest pain, tightness, beside abdominal and back pain. It should be considered if several patients complained at the same time during dialysis from the same symptoms simultaneously. The venous blood becomes more darker, and there is pink plasma, clotted or centrifuged blood. There is drop of hemoglobin, and this is the most serious, the development of life-threatening hyperkalemia if this complication is not recognized. How to treat? We should stop dialysis immediately and clamp the lines, and it's very important not to return the blood to avoid the developed hyperkalemia. And we should prepare to treat this hyperkalemia and the potentially severe anemia developed. We should start investigation for the cause of hemolysis, and the patient should be hospitalized days after this catastrophe to treat or to diagnose the late life-threatening hyperkalemia that may occur. The fourth catastrophe is fatal anaphylaxis. Fatal anaphylaxis reported to occur in hemodialysis patients. Could occur with the ethylene oxide sterilized isomers, the complement activating cellulose membrane, the use of high flux membrane, and some drugs like heparin, iron, ACE inhibitors, etc. It usually occurs in the first 30 minutes from the start of dialysis session, usually usually in the first 10 minutes, except in cases of ethylene oxide allergy that may start later or even after the end of the session. This is the usual manifestation of fatal anaphylaxis. There is, of course, pruritus, skin itching, dizziness, bronchospasm, hypotension, collapse, and shock, may supervene. This is some reports about the occurrence of fatal, acute, systemic hypersensitivity reactions during hemodialysis. How to manage? There is acute management and then later on investigations to identify the offending material that caused this anaphylaxis. We should stop the dialysis session again without returning the blood to the patient, and cessation of any drugs given. Ephedrine should be administered to patients with clinical signs of collapse or presence of developed angionephrotic edema. Antihistaminics should be used in the management of these anaphylaxis beside corticosteroids, and we may use beta-2 antagonist inhalation in case of bronchospasm, and should ensure patent airway. Then we should try to identify the offending material by careful history taking from the patient or even from the treating physician. We can use some diagnostic methods like assay of the IgE. These investigations should be postponed in case of IgE identification 4 to 6 weeks after the anaphylaxis episode because of IgE or the basophil mast mediators depletion or possible influence of these tests by medications that could be used in treatment of this catastrophe. The last catastrophe is the occurrence of cardiac arrest and consequently sudden death. Causes of cardiac arrest includes extreme hypotension, electrolyte imbalance, and most importantly, of course, the occurrence of hyperkalemia, arrhythmias, development of myocardial infarction, air embolism, or blood loss. If the arrest occurs immediately with initiation of the dialysis and the cause is unknown, again, blood should not be returned to the patient unless we discover the etiology of this catastrophe. The dialyzer should be checked. If anaphylaxis reaction due to dialyzer membrane or infusion of formaldehyde from an inadequately rinsed dialyzer should be suspected by a cause of cardiorespiratory arrest during this initial period. And if the event occurs during or intra-dialytically and there is no reason to suspect problems, blood should be returned to the patient promptly and a sample from the dialysate to be sent for analysis. Dialyzer and bloodline should be saved for later analysis. This assessment occurs simultaneously with starting the cardiopulmonary resuscitations. The access line should remain in place. Actually, this is a very important point. to be used as a route for administration of fluids and medications. And after any cardiopulmonary arrest, the dialysis machine should be replaced until its safety features has been evaluated and for possible malfunction. This study reported the occurrence of 400 cases of cardiac arrest among more than 5.5 million patients over a 9-month period. It showed that cardiac arrest was more frequent during the Monday dialysis session, the lengthened duration between the 2 sessions from Wednesday. And it occurs more in older diabetic and patients dialyzed through catheters. And of course, the treatment used for those cases was cardiopulmonary resuscitation with defibrillation. So please don't forget the presence of defibrillator in the dialysis unit. What is the take-home message from this presentation? That resuscitation facilities should be available in the dialysis units, including cardiac monitoring device and defibrillators, suction apparatus, functioning laryngoscope, endotracheal tube, good oxygen supply, and the drugs that are used in these medical emergencies. And we should have a planned preventive maintenance. By this we mean that all machines should have this planned preventive maintenance and technical safety according to the manufacturer. And all these should be documented. Monitoring the patient during dialysis is very important, especially the vascular access and the occurrence of any intradialytic complications and, of course, the vital signs. The patient should be monitored closely in case of dialysis through fistula, blood flow, venous pressure, the occurrence of thrombosis, any skin erosions, aneurysms or pseudoaneurysm, and any infection at the site of the fistula. And in cases of dialysis through catheter, the exit site inspection is very important. And any signs of catheter thrombosis, signs of symptoms related to infections. This is the last slide, and I think this concept should be cultivated, and this is very important to address a culture of safety. Because as you see that the treatment of these catastrophes is prevention. We cannot wait for one of these dreadful events to occur. And secondly, safety should be extended outside the dialysis facility, as we are responsible for preventable events in our patients, only when they are in the facility or in the unit, but at all times. And lastly, best wishes with safe dialysis for all of our patients. Thank you.
Thank you very much, Professor Ayman, for this excellent presentation and for a very important topic, which is dialysis catastrophes or emergencies. And I am so pleased that Professor Mansoura co-chaired this presentation, and I leave him to moderate the discussion.
Thank you, Professor Any questions? So are you tired?
Any one of you have been faced with one of these catastrophes during his practice in the dialysis unit? What kind of catastrophe? Bleeding, dislodgement of the needles?
Merci de cette présentation, elle est très belle, de telle façon qu'on n'a pas de commentaires à faire. Mais au fait, nous avons connu certaines de ces catastrophes, l'arrêt cardiaque. On avait perdu 3 patients. Et souvent, c'est la dialyse nocturne, où c'est le technicien, le médecin le voit à l'entrée, et puis après, il n'y a plus le médecin, il fait appel aux autres médecins. Et quand ils arrivent, il est trop tard de les récupérer. Donc on avait perdu 3 patients par arrêt cardiaque sous la machine. Et aussi, ce qu'on a vu très bien, c'est qu'on dit toujours aux infirmiers de ne pas ouvrir la fissure pour le cathéter. On s'est rendu compte qu'il y a quelques cas des aiguilles qui sont disjonctées et le patient en signe. Mais heureusement, on les a récupérés, mais les arrêts cardiaques étaient très difficiles.
Thank you.
Merci, professeur, pour ce bel exposé. Je vais compléter mon collègue pour rajouter que nous avons beaucoup de cas d'hypotension intradialectique. Les cas d'arrêt cardiaque. Mais les 2 cas qui restent mémorables, là, ce n'est pas lié à la technique médicale, mais c'est une coupure d'électricité. Et il n'y a pas de générateur de secours. Donc on était obligé de restituer de manière manuelle la restitution du sang pour à peu près une vingtaine de malades. Donc risque de coagulation et autres. Le deuxième, c'est un patient de 13 ans qui a fait une hémorragie massive par déconnexion des lignes parce qu'il a fait une crise d'épilepsie qu'on ne savait pas. Une vraie crise d'épilepsie. Et heureusement qu'il a fait la crise pendant la visite. Donc les médecins étaient là et les infirmiers étaient là. Voilà. Merci.
So you see that these cases were due to the unattending the decisions by the physician, or due to needle dislodgement, due to covering the fistula side, and the other one, the cut of the electricity and the machine was stopped. This that we mentioned that we should have a planned and checking of the machine with the instruction of the machine with regular checking. So
Very interesting subject. Patient safety is always very important, and I think to complete what Professor Ayman said, it is a culture that we have to teach our patients, our nurses, and ourselves, because we are responsible at the end. It's our responsibility. This is a concept what Professor Ayman did say. Any other comments or questions? To Samir, Professor Samir.
Thank you, Professor Ayman, for your excellent talk. I think it is very important for all of us as nephrologists, even a nephrologist here, when you will come back to his country, when you will come back to his unit, he must have at least manual for hemodialysis, how to deal with these complications. It is very important for every unit to to have its own manual of dealing with these complications. All complications of hemodialysis must be written, must be assessed, and to write how to manage all these complications. Another point, to complete the culture of safety, every unit must have its own policies and procedures. Policies regarding how to disinfect the machine, how to disinfect the water treatment, how to collect the water samples, what is the frequency of doing the monitoring, the water treatment, vaccination program. Every aspect covering every point in the dialysis unit must be written as policy and procedure. So for every nephrologist, when he will come back to his unit, he must prepare two things, two very important things. First one is a manual of hemodialysis complications, and the second one is policies and procedures for every aspect in hemodialysis.
Totally agree with Professor Samir. These are very important 2 points.
I think we'll have 5 minutes. 5 minutes stop to continue with course at a glance and certificate distribution.